You've probably heard the statistic. Nearly 90% of people over the age of 80 have cardiovascular disease. But this chart shows cardiovascular disease as a massive umbrella category, which includes general high blood pressure. When we isolate the data to actual coronary artery disease, the numbers drop significantly, sitting between 22 and 34. It has grown stiffer. Chronic inflammation has set in, and the vascular cells themselves repair damage poorly due to accumulated biological mutations. Figuring out which of these mechanisms is actually driving late-life heart disease determines our medical response. We need to know whether we are dealing with a simple mathematical accumulation of plaque or a distinctly new disease requiring radically different treatments. To form an atherosclerotic plaque, the arterial wall requires continuous, cumulative exposure to apolipoprotein B containing lipoproteins, the particles that carry cholesterol through your bloodstream. Decades of this traffic initiate the disease. Yet epidemiologists looking at octogenarians often encounter the lipid paradox. In people in their 80s and 90s, high cholesterol sometimes appears mathematically protective in the data, while lower cholesterol correlates with higher mortality. This confusion stems from reverse causation. Frailty, occult malignancies, and chronic infections actively suppress cholesterol levels. In a group of 90-year-olds, a low cholesterol reading frequently signals that someone is actively suffering from a wasting illness, driving the mortality statistics. This line graph plots two distinct lifetime cholesterol trajectories. If we take a single measurement at age 85, both patients register the exact same cholesterol level. But looking backwards, one spent 40 years with high cholesterol before drifting down, while the other spent 40 years low before drifting up. A single late-life reading entirely masks the decades of midlife exposure that actually cause the damage. Lifetime exposure is the necessary fuel for plaque buildup. The math of the stopwatch theory holds up. Decades of lipid exposure are required to drive the disease forward. But the artery itself does degrade. Decades of chronic pulsatile stress fray elastin, the protein giving your blood vessels their stretch. The body compensates by depositing collagen, a much stiffer material. Over time, blood sugars attach to these structural proteins and cross-link them, causing the vessel to lose its compliance. Inside that rigid ball, individual cells undergo replicative arrest, a state known as cellular senescence. Damaged vascular cells stop dividing to repair tissue, but they refuse to trigger their own death. Instead of quietly dying off, these senescent cells develop a pro-inflammatory profile called the senescence-associated secretory phenotype, or SASP. They sit inside the plaque and leak cytokines and matrix-degrading enzymes directly into the local tissue. The aging vessel is actively participating in its own decline. Stiffened walls and embedded inflammatory zombie cells add severe, localized risks to the constant flow of cholesterol. The risk also originates outside the heart. As we age, blood stem cells in the bone marrow acquire genetic mutations. A specific pattern of this is called clonal hematopoiesis of indeterminate potential, or CHIP. These mutations act on leukemia-associated driver genes. The result is a lineage of skewed, hyperreactive immune cells that multiply and dominate the bloodstream. These aggressive immune cells migrate out of the marrow and embed themselves in the arterial plaque. They release a flood of inflammatory signals, accelerating the growth of the necrotic core and roughly doubling the carrier's risk of incident coronary heart disease. The two theories are operating at the same time. The decades of accumulated cholesterol supply the fuel. The stiffening, the local cellular senescence, and the mutated immune cells pour accelerant on the fire. This understanding of aging biology has led to heavy speculation about senolytics, investigational drugs that target and clear out those senescent zombie cells. In early animal models, they are frequently hyped as anti-aging therapeutics for the vascular system. The preclinical reality is highly stage-dependent. In advanced atherosclerosis, the exact condition of most older human patients, senescent smooth muscle cells actually build the fibrous cap that keeps the plaque stable. Pharmacologically clearing those cells out in mouse models stripped the cap thin and increased mortality. Experimental geroprotective drugs have not demonstrated clinical outcome benefits for human heart disease. Because cumulative damage lays the foundation, mitigating the traditional risk factors remains our most reliable strategy, even in advanced age. Randomized trials consistently show that intensive blood pressure control in adults aged 75 and older reduces stroke, heart failure, and overall mortality. Lowering the pressure directly reduces the chronic pulsatile stress on those stiff, aging vessel walls. Dietary patterns also push back against vascular aging. The CardioPrev trial followed 1,000 patients with existing heart disease for 7 years. Those consuming a Mediterranean diet, rich in extra virgin olive oil and low-inflammatory foods, experienced a roughly 25% lower hazard for major cardiovascular events compared to the low-fat group. We cannot yet safely edit out the microscopic breakdowns of an aging human artery. To protect an 80-year-old vessel, the best approach is to ruthlessly manage the lifetime exposure to cholesterol and high blood pressure, starving the disease of the fuel it needs to progress.